Good afternoon, everyone. I am back now. I am Dr. Raju Vaishya. I welcome you all to the webinar on the management of infected total knee arthroplasty. This is the second webinar in the joint replacement subspecialty. I advise you all to post your queries during the webinar so that we can have an interactive session. At the end of the webinar, I'll be addressing all the queries of the attendees. We look forward towards a successful learning program. This webinar is hosted by LEAP web portal. LEAP is a unique digital initiative which contains one of the best AOS products for enhancing and updating the clinical knowledge and skill set of Indian orthopedic surgeons. So let's reinitiate with this presentation. Pain after total knee replacement is a serious problem. It could be due to several causes like loose prosthesis, malalignment of the prosthesis, instability, infection, sensory neuromata, and reflex sympathetic dystrophy. Amongst all, infection seems to be the most feared and dreaded complication after total knee arthroplasty. The dominant cause of failure after total knee arthroplasty is the infection that requires revision. Every patient who presents with a painful total knee arthroplasty should be evaluated for the possibility of an infectious etiology until proved otherwise. Effective management of infected total knee arthroplasty begins with a rapid and accurate diagnosis of the underlying problem, and hence awareness and high index of suspicion about this problem should be there amongst all surgeons who are undertaking total knee arthroplasty. Fortunately, the infection after total knee arthroplasty in primary cases is about 1 to 2% in good centers, but it increases to about 5 to 6% in revision total knee arthroplasty. The furnace in 2002 found that infection and prosthetic designs have a definite correlation. The more complicated designs are associated with higher risk of infection, like unicompartmental knee is associated with the least incidence of infection of the tune of less than 0.3%. TKR without patellar resurfacing, the incidence goes up to 0.3%. Whereas TKR with patellar resurfacing, the incidence goes to 0.7%. So the more you do, the more complicated designs that are used during TKA increases the risk of infection. So how do these cases present? These usually after total knee arthroplasty, pain is the most common symptom that patient presents with. There could be wound drainage and cellulitis that makes the diagnosis, clinical diagnosis simple and obvious. Patients sometimes, those who, especially who are immunocompromised, could be systemically ill with high fever and chills. There could be persistent pain and night pain. And these two symptoms are very typical. If patient presents with night pain, then it should be taken with a lot of seriousness and could indicate underlying infection. An effusion or significant stiffness that has failed to resolve over time despite various conservative therapies, again should alarm bells and should indicate infection. There could be a history of prolonged post-operative wound drainage after the total knee replacement. These may or may not grow microorganism on routine culture, but should be taken as infection until proved otherwise. Radiographs, although plain radiographs are not of great help in acute infections, but in chronic infections, these could be of help because high quality radiographs in suspected infection can show periosteal bone reaction area of bone lysis which again should be seen on progressive radiographs, if it is increasing, that could indicate an infection. Again, on plain radiographs can also show us the overall alignment, the fixation status of the prosthesis, the bone stock that is remaining to plan our subsequent reconstructive efforts. The most commonly done and useful tests to diagnose infection are ESR and CRP, which are universally available. These are useful in all cases of suspected infection. These two tests are useful both for infection screening and monitoring of the treatment over time. And hence, it is mandatory to do these serial ESR and CRP testing in cases of suspected infection. Although both tests demonstrate a rise postoperatively, routinely, the CRP level tends to peak more quickly and then return to the baseline also more quickly than ESR. The rising CRP level more than 1 week after surgery should strongly give you a suspicion of presence of underlying infection. In general, an ESR greater than 30 millimeter per hour and a CRP level greater than 10 milligram per liter warrant further investigation and should be taken as infection until proved otherwise. Synovial fluid analysis is one of the direct tests that can be done to diagnose infection. The fluid which is aspirated should be sent for both aerobic and anaerobic bacterial culture. In some instances, expanding the cultures to include fungi and mycobacteria may be indicated. Many recent studies have noted the value of synovial fluid count and differential counts, and these values may resemble a native joint infection in the setting of acute postoperative or acute hematogenous infection, with a neutrophil differential exceeding more than 90% and total nucleated cells count of greater than 50,000 per liter should indicate infection. However, it must be noted that much lower values can indicate chronic total knee arthroplasty infection, and a leukocyte count greater than 1,100 with a neutrophil differential greater than 60% is suggestive of infection. Various authors over the years have seen and reported sensitivity and specificity of the synovial fluid analysis in the positive predictive and negative predictive values as shown in this chart. There is a recent technique of sonification which is quite useful in increasing the positivity of microbiology after total knee arthroplasty in cases of infection, where we dislodge the adherent bacteria from the removed total joint prosthesis, and because we know that the microorganism may be stuck to the biofilm on the prosthesis and may not be present in the synovial fluid, and hence after dislodging these biofilm and bacteria by the method of sonification, one can have increased chances of finding the microorganism in the fluid. This method may be more sensitive than standard sampling of periprosthetic tissue, and most notably when the patient has been recently exposed to antibiotics that have sterilized this tissue while not penetrating the biofilm layer. The utility of this method will be analyzed further once it becomes more widespread in the clinical use. Given the value of synovial fluid analysis for cell count, differential and culture, it is critical to obtain this fluid before any revision surgery, because this is a direct test that could prove the infection. Low-grade infection can mimic or be superimposed upon many of the aseptic causes of failure. It is the responsibility of surgeon to thoroughly investigate the knee before revision to avoid missing septic complications, and synovial fluid analysis is probably the best performed when the patient has been free from all antibiotics for 2 to 3 weeks. The microorganisms which are commonly involved in causing periprosthetic infection after total knee arthroplasty include gram-positive, gram-negative, and other bacteria. Amongst gram-positive organisms, Staph aureus remains on the top of the list, followed by Staph epidermidis, streptococci. In gram-negative infections, especially in patients with chronic urinary tract infection or lower immunity, E. coli and Pseudomonas are more commonly seen these days. One has to see and look for MRSA and MRAC type of organisms because they are usually very difficult to eradicate with routine antibiotic treatment. Vancomycin-resistant enterococci and fungal infections may also be seen, especially in patients with decreased or low immunity. The cultures of aspirate could be false negative, false positive, and true positive. The false negative is about 25%. These are positive cultures after component removal. False positive culture of aspirate culture is only positive in broth and not in the medium. So it is important that in patients where you do not get the culture, you should send the sample of aspirate in a broth rather than in the medium. The true positive should demonstrate at least 2 or more cultures from different sides of the wound. There are several newer tests that have come up recently to diagnose periprosthetic infection. These are serum interleukin 6, which has very high specificity of 94%. In the synovial aspirate, one can see for leukocyte esterases enzyme, again specificity is high of about 70%, but not as good as serum IL-6. And the most popular of the test these days is alpha defensin, which is again available now for commercial use and is highly specific to the tune of 95%. The tissue testing by frozen section is also considered to be highly specific, although not so sensitive, where you see more than 10 WBC per high power field should indicate infection. Soft tissue culture is probably the most sensitive and specific test to diagnose infection. Synovial fluid profiling of cytokine is a very new test that again seems to be quite promising. Nuclear medicine imaging is sometimes done to evaluate infection at the site of total knee arthroplasty. The combination of indium 111 and leukocyte and technetium 99 scanning has been shown to be very accurate test, but these tests lack specificity and may not be universally available for most orthopedic surgeons. So to diagnose periprosthetic infection, there is no single lab test that can confirm the diagnosis, as these are not so sensitive and specific. However, elevated ESR and CRP at 3 months after total knee replacement should indicate infection. Culture on knee aspirate at suspicion. Synovial fluid leukocyte and differential counts are useful in indicating towards infection. Frozen section of implant membrane and combining PCR with bacterial sequencing is a new test that could indicate periprosthetic infection. Infected total knee arthroplasty can be classified as per the timing of the infection. The positive intraoperative culture from two places, if found positive, should indicate infection. Acute postoperative infection within 4 weeks postoperatively is an acute infection where debridement and component retention with antibiotics, intravenous antibiotics, is the treatment which should be initiated. In acute hematogenous infection, in a well-functioning total knee arthroplasty subsequent to bacteremia from other sites like urinary tract or respiratory tract, debridement and retention of the component, if adequately fixed with antibiotic cover, are usually successful. However, in chronic infection, that is infection more than 4 weeks postoperatively, with more insidious clinical course, usually do not respond to these conservative measures and requires revision of the prosthesis by component removal and subsequent reimplantation in single or second stage, or some other procedures like arthrodesis. So the primary goal of treatment after total knee arthroplasty includes pain relief, maintenance of infection, and most importantly, eradication of infection. So the management strategy should consider the host factor, that is the patient, the local environment of the knee, nature of the infective organism, which is very important, and timing of the infection and the diagnosis when was made. The surgical options include debridement with retention of components, resection arthroplasty, arthrodesis, amputation, exchange arthroplasty in 2-stage or in single stage. And I will discuss all these one by one for you. The surgical debridement with component retention is usually useful in acute infection, that is within 4 weeks. Acute hematogenous infection at the site of a functional well-fixed implant can also be treated by this technique. However, exchange of modular component at the time of debridement to gain better access to the posterior part of the knee joint and allow irrigation of the non-articulant surface of polyethylene insert is highly recommended. Improved results are reported when the symptom of infection have been short-lived and no draining sinus is present. Antibiotic regimes containing rifampicin have shown to improve the chances of success when treating infection caused by biofilm producing organisms such as Staphylococcus aureus, because it has been seen that certain antibiotics like rifampicin, linezolid, etc. can penetrate the biofilm and hence can eradicate infection in chronic setup. This procedure, the second is definitive resection arthroplasty. This procedure has a very high cure rate, but the functional results are often very poor. The result, that is the flail knee, can be considered as an alternative to arthrodesis that allows motion during flexion for sitting, but at the expense of instability during ambulation. And most patients in this era do not accept this. Most patients are now treated with these techniques who are low demand individuals, often in the setting of polyarticular rheumatoid arthritis, etc. Knee arthrodesis is an option, is a salvage option, which sometime has to be considered for treating chronic infection after total knee arthroplasty. The ultimate goal of this procedure is to achieve a painless, stable joint at the cost of the motion. The motions are sacrificed. The relative indication for the arthrodesis include patients with high functional demand, single joint disease, young age, extensor mechanism deficiency, poor soft tissue coverage where you cannot put another implant, host immune compromise, like in chronic kidney patients or severely diabetic patients, highly virulent infective microorganisms. Individuals with ipsilateral hip or ankle disease, patients with bilateral knee disease or contralateral amputations are not considered suitable candidates for this type of procedure. So these are the contraindication for knee arthrodesis. The knee arthrodesis could be fixed by an external fixation or by an intramedullary fixation. Both of these techniques have pros and cons. The external fixation provides excellent tibiofemoral compression and may be adjusted in the post-op period, and it may also be applied at the time of total knee arthroplasty resection. The knee is left free from indwelling hardware, and hence chances of reinfection related to metal and biofilm are avoided. The disadvantages of external fixation, however, include that it does not allow early weight bearing. These are associated with relatively high frequency of pin site complication, and there is substantial risk of non-union. Several people have reported union rate to the tune of 60 to 65% only, even using a ring fixator like Ilizarov surgery. Intramedullary fixation helps allow early weight bearing. It is associated with a very low risk of non-union, and it is best the disadvantages of intramedullary fixation include that it can be performed in staged manner. There is risk of persistent deep infection is higher, and surgical time and blood loss compared to external fixation is also high. Overall, the use of intramedullary rods may be considered a trade-off between fusion rate and infection cure rate, and surgeon must weigh the potential risk and benefits for each patient on a case-to-case basis. The gold standard treatment, however, after infected total knee arthroplasty remains revision total knee arthroplasty, where one has to remove the prosthesis, debride the joint thoroughly, and put an antibiotic-loaded spacer. And then at 6 weeks to 8 weeks, typically a reimplantation of the prosthesis is done under intravenous antibiotic cover. When we plan for revision total knee arthroplasty after infection, there are certain tips and tricks that goes with this procedure. Like antibiotics are typically withheld until all the deep tissue cultures have been obtained. In most cases, the knee should be accessed through the previous anterior incision after excising the previous scar. When multiple incisions are present, the more lateral longitudinal incision that allows appropriate access to the knee is typically used to avoid devascularizing the skin flaps. If there is a transverse incision for previous surgery, that should be transected at right angles wherever possible. And a plastic surgery consultation should be taken in patients with preoperatively where you have multiple skin incision, and if you feel that there could be need for flap coverage intraoperatively. Or the tips for exposure of these knees are not simple to expose because there are a lot of stiffness, scarring, and the tissues are adherent to each other and to the prosthesis. So expose the knee to facilitate component removal and debride while protecting the soft tissue with grade to maintain the integrity of the extensor mechanism. It is very important that you protect the extensor mechanism, which may be damaged during this surgery. In most cases, The patella can be subluxated rather than everted to minimize the tension on the patellar tendon. So we must try to prevent patellar tendon avulsion by everting by subluxating rather than everting the patella. The quadriceps snip and tibial tubercle osteotomies are another two tricks that can be used in difficult cases to give you an extensile approach where more dissection and more exposure is required. So once you have exposed the infected TKR, then second step is to remove the existing prostheses. This is facilitated with the use of variety of instruments that are available. The use of flexible osteotome and oscillating saw blade is the most commonly used instrument. Many implant-specific extraction devices are also available these days. Ultrasonic cement extraction tools may be needed when removing cement stems from femoral or tibial canal. Although these are expensive instruments, but are quite useful, and if you can get hand on to it, then nothing like it. So once you have removed the prosthesis, then you do prepare the bone for further action. The goal of debridement is to remove all foreign material and necrotic tissue while maintaining the vascular supply to the bone. Once the components have been removed, the bone must be evaluated carefully for any retained cement on the condylar or intramedullary surfaces. It is helpful to reassess the final soft tissue debridement after component bony debridement has been ensured, as the capsular recesses will now be fully exposed. So extensive debridement of the soft tissue and bone is mandatory is in the first stage of revision total knee arthroplasty. So once we have removed the prosthesis, debrided the soft tissue and bone, then we have to fill this gap with antibiotic spacer. These antibiotic spacers are quite useful as they provide antibiotic delivery in postoperative period until the second stage. They give greater patient comfort and improve the soft tissue healing and tension. And it also enhances the bone quality when you go in for the second stage revision total knee arthroplasty while putting the implant at the second time. There are various types of cement spacer that can be made with the help of Palakos cement or Simplex P cement. The Palakos cement gives you a superior antibiotic elution due to higher porosity, and you can add tobramycin or vancomycin in high concentration as mentioned here. Simplex P cement has superior handling characteristic, and again one can add variety of antibiotics to this cement in high concentration to make use of cement spacer. There are various antibiotics that are commonly used in making these spacers. These include gentamicin, vancomycin, tobramycin, erythromycin, cefuroxime, ciprofloxacin, etc. The prerequisite for all these antibiotics which are being mixed with bone cement is that these antibiotics should be heat stable and are used in high concentration. The advantages of spacer in two-stage revision include adequate delivery of antibiotics in postoperative period. They give you second opportunity for debridement. It improves the function and quality of the patient with the use of these spacers. Here are some of the steps you can see while reimplanting the prosthesis at a two-stage revision total knee arthroplasty. Here is a case with infected total knee arthroplasty. You can see radiolucency in the medial tibial condyle as well as on the lateral tibial condyle, which is confirmed by 3-phase radioisotope bone scan with increased uptake in immediate blood pool phase and after 3 hours of the injection of radionuclide. This was converted into 2-stage revision arthroplasty, whereas in the first stage, antibiotic loaded cement was put in as a spacer for 6 to 8 weeks, and then revision total knee was done. Avoiding pitfalls with the antibiotic loaded cement is also important to understand, because one must add the antibiotics after the cement has been mixed into its liquid phase. Avoid the use of premixed low-dose formulation at the time of treatment. The recommended treatment dose is typically around 8 grams of antibiotics per 40 grams of bone cement. So it's pretty high compared to what we normally give as intravenous antibiotics. Shaping of bone cement dowels is very important to facilitate their use. This is very easily performed and requires reducing the size of the proximal flare to a lower profile. The most common mistake is to leave this segment too large and then overstuff the joint, and this must be avoided. Now, instead of making these antibiotic spacer, one can go for commercially available articulating spacers, as shown in these pictures. Each type of spacer allows for delivery of antibiotic to the site of infection, stabilization of the soft tissue envelope, facilitation of the subsequent reconstruction, and improvement of the ultimate clinical outcome. These mobile spacers preserve joint motion during the treatment and facilitate surgical exposure at the time of reimplantation when compared to a static spacer. The use of mobile spacer is typically reserved for patients presenting with simultaneous bilateral infected total knee arthroplasty, which is fortunately not so common. The static, that is non-articulating spacers, are simple, incongruous, performed blocks of antibiotic-loaded bone cement. The problems related to these spacers, however, include migration, bone loss, instability, erosion of periarticular soft tissues, and to address the issue of migration, the molded arthrodesis block was developed. The antibiotic doses used in antibiotic-loaded spacers, as I mentioned earlier, is much higher than the doses used at the time of definitive joint reconstruction. And this message must go through with all the surgeons who are dealing with infected total knee arthroplasty. The use of premixed low-dose antibiotic formulation should be avoided in these patients. Final decision to implant or not to implant must be seriously discussed and considered by the surgeon who is treating these patients. Evaluation of gross and microscopic appearance of tissue is one indication which a surgeon can appreciate to decide whether it should go for reimplantation or not. A cutoff value of less than 10 WBC per high power field is used at frozen section, which shows greater specificity but a lower sensitivity for diagnosing ongoing infection. If the infection appears to remain infected at the time of intended reimplantation, deep cultures are obtained, a thorough debridement is performed, and a new antibiotic spacer is inserted. This is an awkward situation for surgeon who has planned for two-stage procedure and explained to the patient, but once he goes inside and find infection, then obviously it is an awkward situation, but one must take the patient point of view in consideration, patient safety, and should not be hesitant in debriding, putting a new antibiotic spacer, and going in for third stage surgery in these patients. At the time of reimplantation, be prepared to manage any soft tissue related to the losses to bone loss, extensor mechanism disruption, or collateral ligament injury, as in all other types of complex knee reconstruction. At least 3 tissue cultures should be obtained at the time of reimplantation in all cases, so that you, in case you have residual infection, you can grow microorganism and can then give antibiotics accordingly. Evaluation of preoperative cultures before second stage reimplantation could be of great help to the surgeon. One must stop antibiotics after 6 weeks of first stage and wait for another 4 weeks. Then take a knee aspirate for culture. If there is no great growth, then you go for reimplantation. However, if you find some microorganism growth, then repeat 6 weeks of antibiotics and then repeat the same procedure again. The success rate after doing this type of drill increases the success rate significantly. So once you have decided to reimplant, then you must know the details of the first implant which was implanted. You must be ready with the appropriate instrument. You must also be ready with appropriate implants, which are quite different than primary implant. The revision TKR requires special instrumentation and special implants, as you all know, as shown in this picture as well. Here are the revision total knee arthroplasty implant showing long stem. Here is a case who had total knee arthroplasty revision after total knee arthroplasty with long stem. The contraindication for reimplantation include persistent or recalcitrant infection, medical condition that preclude multiple reconstructive attempts, several disruption of the local soft tissue envelope, like extensor mechanism, systemic condition that predisposes to infection. The results of 2-stage total knee arthroplasty have been published by various authors in the past and has shown good result to the tune of 88 to 95% over 10 years, and hence this remains the gold standard treatment for total knee arthroplasty. There are several reported publications on this 2-stage revision arthroplasty, which gives good result in most hands. And hence it remains a gold standard treatment with success rate of more than 75 to 80%. And these 2 stages are done at 6 to 8 weeks interval. Recently, some authors have published their series on 1-stage revision of total knee arthroplasty, and 1-stage revision should only be considered in patients who have low-grade microorganisms that are cultured preoperatively, and you know the antibiotic sensitivity for these microorganisms. Soft tissue coverage is very important in some patients, and help of plastic surgeons must be sought. Medial gastrocnemius flap is excellent. Transfemoral amputation must be considered in some unfortunate patients with less than 5% of all infected TKR. The indication for amputation include life-threatening sepsis, multiple failed attempts at the eradication of infection, and non-reconstructible bone loss and intractable pain. So friends, infected total knee arthroplasty is a story of decreasing success, and hence prevention is better than the treatment in these patients. And one must be very, very careful in preventing these infections, take all the necessary precautions at the time of primary surgery. Thank you for your kind attention. I acknowledge the paper published in AOS journal by Mabry et al. For this presentation. Thank you. Any questions? I'll go by sequence. Dr. SN from Nigeria is asking about the criteria for single stage or 2-stage revision. As I said, 2-stage revision remains the gold standard in most cases, but single stage revision can be performed successfully in selected patients where you have low grade virulent microorganism where you know their nature, you know the culture sensitivity, and you can give appropriate antibiotics post-operatively. Otherwise, in most cases, two-stage revision still remains the gold standard. Dr. Jacinta, about your question on the arthroscopic debridement and antibiotics and implant retention, I have already mentioned this technique is only useful in early infection, that is infection within 4 weeks of the primary surgery and where the prosthesis is not loose on the X-ray. In these cases, arthroscopic debridement with retention can be performed, but these cases are less common than patients who present with chronic infection. Dr. Kinjal, I think I have already answered your question on debridement, antibiotics, and implant retention. It is very hard for any arthroplasty surgeon to sacrifice his prosthesis, and then hence they try to extend the indication of arthroscopic debridement in their patients. But in my experience of almost 30 years, I feel that this procedure is only useful in patients who have active infection in early stage or who are seriously ill due to systemic infection related to infection after total knee arthroplasty, where more extensive surgery could not be performed. Dr. Nilesh, your question on following debridement, what should be the duration of antibiotics? Usually the antibiotics given, if you know the microorganism and if you know the sensitivity, these patients should go on intravenous antibiotics for at least 2 to 3 weeks, followed by oral antibiotics. But before second implantation, these antibiotics must be stopped for about 2 weeks or so, and then you repeat the aspiration of the joint before going in for second implantation. Dr. Rutuja Raut from Pune, welcome here. The single stage revision of course offers reduction in cost and morbidity, but this is still not the standard treatment for all infected TKR, because in most infected TKRs it is very difficult to eradicate infection in first go, and you cannot take a chance of reimplanting. And in many of these cases you will find, in fact in majority of the cases, that you may not be able to grow any microorganisms. So you don't know what are you fighting with, and hence two-stage revision may give you a better option for reconstructing or saving these joints. Vishal Gindwani from Indore, sonification is a process where, with the help of a machine that involves ultrasound guided blast on the prosthesis that liberates the microorganisms attached to the biofilm. Unfortunately, this technique is mentioned in the literature, but we don't have this facility available in our hospitals as yet. Piyush Kashyap from Jabalpur, in revision surgery, which type of stem fixation is preferable? In revision surgery, usually, since you are using antibiotic loaded cement, Of course, cemented prosthesis and cemented stem must be used, but due to complexity of the anatomy in the proximal femur, in the distal femur and proximal tibia, one may have to use various type of stem that can offset the deformity, as I had been shown in earlier in this one of my pictures. Piyush Kashyap, Balakrishnan from Guntur. I have already answered your question in my presentation. Antibiotics that are commonly used are gentamicin, vancomycin, erythromycin, etc. Tobramycin. Dr. Vinod from Guntur, best way to treat type 1 IV infection. I couldn't get your question well. Dr. Lokesh from Guntur again, so a lot of people from Guntur. What do we do in period between two-stage reimplantation? Oh, that's a good question. You basically put the patient on intravenous antibiotics for about 3 weeks, followed by oral antibiotics. Take serial ESR and CRP. If the trend is towards regression in both these parameters and patient is clinically stable, do not show any sign of infection, then patients are mobilized, non-weight bearing, in a splint or a cast, and then when you think that ESR and CRP have come to near normal, then you stop IV and all antibiotics, wait for 2 weeks or so, aspirate the knee again and see if there is any microorganisms that are growing. If not, then you go in for second stage revision, reimplantation of the prosthesis. Dr. Siva Reddy from Guntur, can we allow patient to walk full weight bearing? No. Cement is not strong enough, cement spacer is not strong enough for you to allow patients to take weight on it during the waiting period, and hence not weight bearing should be recommended. Aditya from Guntur, which is the best diagnostic tool for detection of, as I mentioned in my presentation, recently synovial fluid aspiration and detecting defensin, alpha defensin, seems to be the most promising in infected TKR. However, intraoperatively, if you can get frozen section done, then that also increases the sensitivity and specificity of your diagnosis. Ayaz Ali from Mumbai, how to mobile and immobile joint spacer help for patient to get rid of infection? Basically, these spacers are maintaining the gap that has been created by removing the prosthesis, and at the same time gives you the antibiotic concentration locally. The mobile spacer give you the freedom to move the joint, whereas static spacers keep the joint immobile. There are pros and cons of both, which I have already discussed. What are the absolute indications for knee arthrodesis? Again, have been already mentioned. The absolute indication could be infection which is not going with whatever you have done, patient who have already had multiple surgery, patient who cannot afford the two-stage revision total knee arthroplasty, because that is quite an expensive and time-consuming procedure with unpredictable outcomes, not 100% outcomes, to about 80%, and hence in these patients you can discuss with the patient for arthrodesis. Dr. Ram from Guntur, what are the complications of using such a high dose of antibiotics in cement spacers? Usually these antibiotics are safe to use locally in high concentration, and no toxicity have been reported by any authors to the best of my knowledge. Dr. Rajat Saran from Bhopal, how do you manage infection with tibial bone loss? So obviously you have to eradicate the infection, and if you have a tibial bone loss, then that can be managed now with various type of metal substitute that are available with the prosthesis that can be fitted with the prosthesis. People have also tried using allograft in this situation to fill in the tibial bone loss. From Hubli, Dr. Hari Krishna asked, what is the antibiotic of choice pre-operatively? One should not go for high-end antibiotics in primary total knee arthroplasty situation. Usually it is recommended that one uses second generation cephalosporins like cefuroxime or coamoxiclav with aminoglycoside for 2 to 3 days. That is usually quite effective and sufficient for most patients. Dr. Fuljale and Dr. Pranay from Raipur, is it routine use of antibiotic loaded cement? In my practice, I do not use antibiotic loaded cement in most cases, primarily unless these patients are higher risk. Higher risk means patients who are immunocompromised like rheumatoid arthritis, patients who are quite obese, patients with severe diabetes, and so on. Otherwise, plain bone cement is quite sufficient. Dr. Hari from Hubli, your antibiotic of choice I've already explained. Hoffman technique. I am not aware of which Hoffman are you talking about. Sorry. Thank you, everyone. Once again, I thank you all for participating in this webinar and making it quite interactive. Thank you.